questions the gentleman had.
Yes.
And whether they are being reasonably well answered or not.
And I just want to ask, the gait analysis will improve by doing soft tissue surgeries or body surgeries. Will her GMFCS level from 2 to 1
No.
get be there?
No. So why is that so?
Energy required for the gait, it will be reduced. So why not?
So
our aim should be to increase the energy
Cost
utility.
So you're very right. If you put a 4-liter V8 engine into the Nano, you could make it go much faster. But the engine would weigh the Nano down so much that it couldn't go anywhere. And the problem with using the GMFCS as a kind of a vision or as a goal is where the first mistake is made. The GMFCS is not judgmental. The GMFCS is only a way of saying, how is this child walking in this large number of things that people use to walk. And it says that for the people who were measured, the children and adults who were measured, they kind of measured their individual function through what is called as a GMFM, which is a very pinpoint scale, as the physios will know, to say, how are you doing this? Are you doing this? And the more you do, can you climb Mount Everest? You get to 100. Right? So we know that children with cerebral palsy can be anywhere along that scale. And each child will get to a particular level on that scale based on where they are born, what facilities are available, what infrastructure is available to them, what access to services they have, what is their own innate desire to do more than what they are doing, what does their society help them with. So it is very individual to that person, and the scale does not differentiate that. So when you use the scale to say, my child has reached this scale, but I want them to get further, it is the same as saying, my child got a second class in the exam, but I want them to get a first class. The scale doesn't do that. What we would use for that is something called the FMS. The FMS is a functional mobility scale, and it has 3 components. And it says, what do you do indoors? How do you work, how do you move outdoors, say outside this room, and how do you move outside in the community? And you recognize then that children or adults may do things differently. But their GMFCS scale may still be the same. If you are here on Saturday, I will show you in my talk that the GMFCS is only a way of saying how do you identify what this child's capabilities are. You do not use it as a way of saying I want my child to get to this level, because the weakness is because of the brain lesion. We cannot change that. The spasticity is because of the brain lesion. We cannot change that. The selective motor control is because of the brain lesion. We cannot change that. So in the context of what the cerebral palsy does, there are only a few things we can change. Some of the things we can change are measured using this. Some of the things we can change are measured by physical examination findings. If the two match up and we have a conversation that says that this is identified as a problem, this is likely to get worse in the future if it is not corrected, and therefore the function will drop because this problem will make the child's life worse, you may have a justification for doing something to prevent things from getting worse in the future. Now that is a more powerful intervention than trying to aim for something better which the child cannot do. So as a parent, even though you desire the best, sometimes the pathology will not give you that. So this is only a means to an end. The end is decided by many things, and some of them are not in our control. I hope that is a satisfactory explanation.
Do you do data analysis and follow-up for all your patients?
Absolutely.
When do you start doing that?
So we would use a combination, see the 3D gait analysis itself with all the kinematics. How long does it take you, Jay, to get all the data?
The actual process takes about a couple of hours.
So it's about 2 hours or 3 hours depending on how much you want to
plus an hour of process.
After surgery to
So for a child who is recovering from surgery, we would not do the 3D analysis till 12 months after. And what we would do at the 6-week, 3-month, and the 6-month mark is just a simple video. to say how they're doing and to address the child and the parent and the therapist's concerns as to are there any issues that are affecting the rate of the child's recovery. And what we have shown is that when you look at this data over a period of time, you recognize that the function actually drops, as you would expect it to after multi-level surgery. It drops, it starts to climb up and then starts to continue to improve for a period after that. And that period is dependent on what the child can actually improve to. So that's how we decide how often to follow it up. But it is important to keep track, otherwise you never know how well you're doing.
And your indication is it for all patients or only
All walking patients, all ambulant patients with cerebral palsy, so that's GMM says 1, 2 and 3. If they are to have any surgical intervention, we would prefer to base that intervention on some video information that's collected and then a 3D gait analysis before their intervention is actually done. It's the same assessment process for if they're going to have a selective dorsal rhizotomy or if they're going to have an intrathecal baclofen pump for walking patients. You need to have some way of measuring all those different things that we measure. And that's where we would do it.
So I do gait analysis on all interventions, including Botox now. So even if I'm doing a Botox for the first time and the child is a walking patient, I always do a 3D gait analysis because 3D gait analysis costs less than a CT scan. So compared to the cost of the intervention, the cost of the scan is very less. So it will improve the efficiency. You know, if sometimes, particularly with Botox, I change muscles depending on what the 3D gait analysis shows. Sometimes I want to inject the calf, but I actually see that it is a apparent equinus and I have to inject the hamstring or the psoas. So just change the position.
for this post-plasticity issues in the quadriceps and hamstrings? Do you rely on EMGs or
So this girl also has EMG.
It's a very good question, right? Is how can you add another layer of assessment to another layer of understanding to what's causing the problem? And the EMG then is that additional layer.
So you can see the reason I chose do a left rectus transfer, not a right rectus transfer, is because she has got phasic activity of the right rectus femoris. So you can see that sometimes it is on, and in the swing it's actually off. Whereas on the left side, she has got very, you can clearly see the difference in the pattern of activation of the left and right rectus. And I actually picked up some positive rectus scans on the left side. So which is why I decided to do a left rectus transfer. But I'd be the first to agree with Dr. Cote that, you know, it's always, if in doubt, always wait. Don't do a surgery, just wait. It can always be done at a later stage if required.
Can we try Botox for rectus?
Absolutely, that's also a good idea.
So the intervention is based on a lot of things, right? You don't necessarily have to choose surgery as the only intervention. What we would use is what are we trying to achieve based on what impairment have we picked up. So the understanding at our level is what are the gait features from the physical viewing of the child to looking at the video. What are the gait features on the kinematics, that is the joint angles. What are the gait features on the kinetics, which is what are the forces working on the different joints. From that we will make up a list of impairments. And the impairment is a collection of findings from each of those things that explain why that's a problem. And then we would look at what intervention will address that impairment. So for example, you may have a visual impression of a flexed knee gait. You would have a physical examination finding of a hamstring contracture, and you may have a kinematic that suggests a flexed knee during gait. And we might address that by a hamstring lengthening stroke transfer as a means of addressing all those three features. So the intervention at the end is based on what we have collected before. If, like this, we found that the spasticity was a cause of the flexed knee gait but not a contracture, then the impairment would be hamstring spasticity. It wouldn't be hamstring contractures. So then the intervention would be spasticity treatment. So what we are trying to address with this is getting rid of all the descriptive terminology that you use, like we saw in the slides that my poor neurosurgery friend just talked about. He was given the slides and he spoke about it, and the material on the slide didn't give us any idea what was actually happening, till we actually broke it up into little pieces and then worked out individually what each section meant, and then worked out what to do as a consequence. So I think that's probably where this tells us how systematic you have to be. Wouldn't you agree? I mean, we as surgeons, we are taught to fix and forget, but this teaches us to be very diligent in our assessment.
I think to summarize the case without explaining the role of physical therapy will be unjustified here.
Okay.
So I basically request the audience to support the faculty. What are the 5 components of the physical therapy should be with this child? The components of the physical therapy. What are the 5 components should be considered most important in this case? Any one of you please. Any suggestions? The components of physical therapy, there are so many physical therapies we have here. What are the essential 5 components should be there?
Strengthening.
It's basically muscle space. Okay, and what's the other? Orthotic aids, very good.
Also any other walking aids?
Mobility aids, yeah, very good.
Where the child is going.
This is 3, again 4.
Somebody else can.
Anyone please? Sorry? Maintain the flexibility by
regular stretches.
by stretching. You want to say stretching?
Active stretching.
Active stretching, activity. Okay. And any other? Sorry? Stretching to maintain. Balance training. Okay. See, there are so many essential components. Thank you. There are so many essential components when we are working with the child. Here, the role of stretching. The first, actually, you can say activity the therapist does with every cerebral palsy child is very minimal. You have to be very cautious. As for example, as Dr. Abhay actually explained about the role of orthopedic surgery in the tendo Achilles. It is very much controversial, the stretching of the TA, plantar flexor with the diplegic children. Yes, with the hemiplegic children, it is permissible, mostly because the progression of the disease or disorder does not go to calcaneus so fast, or very rare. But with the case of diplegia and quadriplegia, the disease progression will automatically go to, you can say, calcaneus in the long run if it is not cared for. So the role of stretching with the plantar flexor, especially the soleus. I hope the therapist knows the difference between the stretching of the gastrocnemius and soleus. We will actually, in the next sessions, we ask at least 2-3 volunteers to show how it is done. Most of the people will be surprised how basically most of the therapists do it. So the role of stretching, yes, it has got role. But stretching by activity, as ma'am says, will be better than stretching. Because activity has got 2 components. One is stretching, the another is strengthening. Because now, the present scenario with cerebral palsy management, one article says there is no matter with spasticity. In other words, they say spasticity does not matter with cerebral palsy. We have actually on the battle, but we are very poor in our strengthening protocol. There are very few, you can say, activities or protocol available in the world which can strengthen the muscles. That is one of the, you can say, research topics all over the world. The third is posture enhancement. That is very much important. You have to achieve the postures, the remaining postures, and at the same time you have to maintain whatever the child has got. That is called functional enhancement. Gait training, because the child is in the growing phase, the gait is deteriorating. So you have to maintain the gait and you have to enhance the gait also because the energy cost is very high. So the role of mobility aids is there. There are other modalities also. I hope there are so many physical therapists will support controversial things. Maybe use of the modalities. You can say electrostimulations. There are so many other things. Neurotherapy by feedback systems. There are horse therapy. There are psychotherapy. So many components are there. With or without surgery, the role of the therapy will be intact with this child. Thank you. Any questions, please? The parents are there.
Went through a gym program,
Yeah.
and they were adolescents, and their functional benefits were really good,
Very high.
but they dropped off very quickly as soon as they stopped the training. It kind of deteriorated again. But it's an important thing, and my feeling generally in this is that we are a medical faculty, and we try to think of life as being what happens to us when we are at work and in our offices or clinics. But for the child, I think what happens at school and at home is probably more important and more relevant. So anything that can be done to enhance the physical benefits they get from activity at school and at home is more likely to work than the half an hour or the hour that they spend in the therapy center. So my advice to parents is to find the closest playground. My advice is to try and find the closest kind of disability, sport and recreation outlet that they can get to, and then to try and work with those goals in mind, because it is more about participation of the child in those activities than how much stretching they do with someone. So most children will get institutionalized with this because all they remember is going to a clinic and getting someone to push and pull
every day in some children twice a day.
That is too much.
And then again we have to
And it is misplaced confidence in your ability to create that change.
Yeah.
Because then they depend on you to provide the result. And like I said, the result is based on many other things, not in our control.
That's why there is a sentence, as a therapist, please change the role of the therapist from the center to the park. If you can modify the role from the center, definitely the child will learn more. So we have to work that way. And again, another thing that is controversial, but it is coming up in the literature, the negative effect of stretching. There are so many children who are not adult, they are showing arthritis. A few literature support the idea of excessive stretching. So you have to think about that also as a therapist. That is also important. Thank you.
Thank you, Dr. Mansur Alam and Dr. Abhay, everybody. But I would really like that we have in this audience very senior person.